face-to-face preoperative education classes for patients undergoing total joint arthroplasty. The design of this study is an integrated systematic review of the literature. As I have worked in an orthopedic inpatient floor, I have encountered many patients that were undergoing elective total knee or hip arthroplasty. Many of these patients vocalized concerns about their surgery and felt that they were still not fully prepared and had many questions. As a nurse, I could assess that these patients were still not fully educated on different areas of their surgery, and many studies researched agree with the same concept. Many patients stated that only standard education was provided, going over only risks and minor details of surgery. There is a need for research in providing preoperative education for patients undergoing total joint surgeries because pain management issues, poor quality of life, and unrealistic expectations are common experiences in patients preoperatively. Patients are in need for a definitive resource other than standard preoperative education that will allow full understanding and preparedness for upcoming surgery, and that will also lead to a faster recovery and shorter length of hospital stay. There are no existing clinical practice guidelines for face-to-face preoperative education classes in total joint arthroplasty. My PICO question states, in patients undergoing elective total joint surgeries, does attending a face-to-face multidisciplinary preoperative total joint surgery class versus not attending the preoperative total joint class impact knowledge and functional outcomes such as improved recovery time and shorter length of stay? Without effective preoperative education, patients will experience a longer hospital stay, poor quality post-operative experiences, increased complication rates, and higher readmission rates. Post-operative complications, increased hospital length of stays, and hospital readmissions could cost up to $25 billion per year. The cost per day in the hospital for patients can range between $2,000 and $3,000. In this review, conceptual definitions included patient education, total joint arthroplasty, and recovery time. Multiple databases were searched with results of limited studies. Using search terms such as preoperative patient education, length of stay, educational needs, total hip arthroplasty, total knee arthroplasty, self-efficacy, recovery time, patient outcomes, and osteoarthritis. Studies were included if they were primary full-text research regarding effectiveness of face-to-face preoperative education in English language, published within 2003 to 2016, and met the quality appraisal minimum of 3.5. Studies were excluded if they did not involve total joint arthroplasty, total joint preoperative classes that did not meet the quality appraisal minimum of 3.5, or if they were review literature studies. These criteria were used to refine results of studies that related to the PICO question. Studies were all screened using the Quality Appraisal Review checklist. Only 6 quantitative studies were used and placed in an evidence table in this review, and the only limitation of studies reviewed was that patients undergoing revision procedures or other forms of arthroplasty were excluded. These studies strictly included knee or hip arthroplasty. In the synthesis, 2 randomized controlled trials, 3 cohort studies, and 1 quasi-experimental study were used in this review. 5 of 6 studies show that face-to-face preoperative education positively affected length of stay and functional outcomes. Studies included different variations of education supplementation within the face-to-face method, such as using multidisciplinary teams, binders, booklets, and educational packets. Only 1 study showed no significant findings in functional mobility and length of hospital stay. Quantitative studies similar to those used in this evidence table show that the patients that did receive face-to-face preoperative education method reported lower levels of postoperative pain and better postoperative functional mobility. Improved patient satisfaction, decreased cost for both patients and hospitals, and reduced hospital readmissions and other benefits that face-to-face preoperative education has impact on. This review provides evidence suggesting that there are both benefits and non-significant data associated with the use of preoperative education in total joint arthroplasty. Personally, I believe that additional quantitative studies should be conducted in order to develop clinical practice guidelines and provide concrete results in the effects of face-to-face preoperative education.